Yeah. Hello, friends. So I'll be just giving a little overview. I think in the last video you may have seen, I was looking at covering the 9 myths in nutrition, which was a beautiful article that came out in Advances in Nutrition. So I covered the first myth, which was all about early enteral feeding. Does it make a difference? And we all concluded, yes, early feeding does make a difference. So now I'll talk about the second and third myth, which is also important. So I have few buffoons sitting with me. So I'm going to ask an exam going final year DRNB who has passed his theory and he seems to be ecstatic. So whether is there any difference with regards to gastric feeding versus post-pyloric? So for nomenclaturing, I would use uh, gastric as pre-pyloric feeding and post-pyloric feeding, or we call it a small bowel enteral nutrition. So is there any difference when we feed someone gastric versus post-pyloric or small bowel enteral nutrition? And are there any studies, Pradeep? Quickly, because obviously this is not a dialogue that we're having, it's just a talk. Okay. So my final year DRNB who's giving exam says in pancreatitis, when there's increase in gastric residue, he would wish to use post-pyloric, and he's telling that there's no difference. So let's look into what the evidence is. I think he may be right. So the myth that exists is significant clinical differences exist between pre-pyloric and post-pyloric feeding tubes. That's a myth. We want to debunk this. So this is a myth that there is a significant difference between pre-pyloric. When we say pre-pyloric, it is gastric. So you see this tube sitting in the stomach. So we feed into the stomach. Post-pyloric is we feed into the small bowel. So we'll call it a small bowel enteral nutrition. So if you look at the recommendation and the evidence, early gastric route appears to be beneficial and it is not inferior. Okay, so when I say more beneficial, it doesn't mean it's more beneficial than the small bowel enteral feeding. It is more beneficial for a simple reason that you are able to feed early without having to go through the logistic difficulty of putting in a post-pyloric tube. So the pre-pyloric, which is gastric tubing versus small bowel feeding, there is no difference when you look into. So is there any studies to look into pre-pyloric and post-pyloric? So the reason is why it is more beneficial is it is easier to place. So when you talk about gastric feeding, you don't have a technical difficulty of having an endoscopy to be inserted or to having other gadgets to facilitate to be put into the small bowel feeding or post-pyloric is easier to place and it is quicker. So our current understanding is there's no difference either post-pyloric or pre-pyloric. You can stick to gastric feeding. It is quicker, easier, and you wouldn't delay in initiating the enteral nutrition, which is the primordial purpose when we talk about enteral nutrition. Are there any studies? So there is this study which came in 2012 from Australian group, a multi-center randomized control trial comparing early nasojejunal and nasogastric nutrition in critical illness. So in Australia, where I also work, so the whole concept of gastric. So here they took patients where they had increased GRVs, increased gastric residual volume, and they continued. They compared between gastric and post-pyloric. They took patients who had increased GRV within 72 hours. So these were the patients which were taken for this study. And they had 181 patients, 89 where they were gastrically fed, 92 underwent small bowel enteral nutrition. And when you look into the hospital mortality, there was no difference between gastric or post-pyloric or small bowel enteral nutrition. And what they showed is small bowel enteral nutrition, although it showed trends towards reduced pneumonia, because these are the patients who had high gastric residual volume. So the risk of aspiration would be higher and the risk of pneumonia was higher. Although the mortality has no difference, but definitely the rate of pneumonias was lesser in post-pyloric feeds or small bowel. And they looked at nutrient delivery, whether there's any difference because of GRVs being high, including the nutrient delivery appeared similar between the gastric and the small bowel enteral nutrition, and there was no difference. Then they looked at aspiration because you would think that someone who has an increased GRV, the risk of aspiration, all the pneumonias was less in post-pyloric. Aspiration, if you see, there was no difference between gastric and small bowel enteral nutrition. And the suggestion is small bowel enteral nutrition could be considered mainly in certain distinct situations where there is delayed gastric emptying or where there is foregut surgery. As my DRNB exam going guy said, in special indications like gastrectomy, pancreatic jejunostomy or Whipple's or gastrojejuno bypass, distal pancreatectomy. So one could consider small bowel enteral nutrition where your gastric emptying could be delayed. So this is our understanding. So we have evidence to suggest there's no difference. You can stick to your gastric feeding, but in certain situations where there is a delayed gastric emptying or where you have abdominal surgeries, of course, in abdominal surgeries, you would have a judge tube being put in, and invariably they would be on judge feed. So these are the situations where you could think of post-pyloric or small bowel enteral nutrition. Now we'll talk about the third myth. So again, I would ask the question. So in our ICU, we do pretty much more of intermittent feeding, but in some we do continuous. So is there a difference? So the myth is continuous is preferred over bolus central nutrition for the prevention of aspirational intolerance. So I'm going to ask another buffoon, my DNB, Dr. Lohini Roy. So tell me, is there any difference between continuous versus bolus intermittent feeding? And would you prefer continuous or would you prefer bolus? Quickly, I don't have time because my audience is keen to hear out what the. Okay, so my first year DRNB training says bolus is preferred. So the notion is that many a times when you go hear out some lectures on nutrition, so there is sort of signal telling, okay, maybe we should do continuous feeding and the bolus feed tolerance can be affected. So that's the notion that feed tolerance is affected and the glucose variability because you're giving a bolus, tolerance may be affected and your blood sugar sort of a variability also will be more and controlling glycemic control also becomes difficult. So that is the sort of a notion. But largely we have understood there's no strong evidence to suggest that continuous is better than bolus. In fact, continuous feeding is non-physiological because we don't eat food continuously. So it is non-physiological. So if you apply common sense, then bolus appears more physiological. So that's what the evidence says. So the recommendation three is when you compare intermittent versus continuous, there's no difference with regards to outcome. And the continuous, the only argument in favor of continuous is it limits GI intolerance and it limits glucose variability. This is the arguments in favor of continuous feeding. But if you obviously we're all evidence-based medicine, so we have to look into any studies that are done. So this was a study that came in 2022, comparison of continuous versus intermittent enteral feeding in critically ill patients. This was a meta-analysis. In fact, here they took very many articles. I think they took around more than 100 articles and then they distilled out the key articles which could possibly send a good signal. And they took 14 studies. They took 14 randomized controlled trials or observational studies. And this also came from Australia, trying to compare whether continuous is better versus intermittent. They showed one signal which tends to favor one over another, continuous. So as you see, what they showed is they took 14 trials. In fact, the one which went against continuous was the risk of constipation. Constipation was more in continuous as compared to intermittent because the relative risk was 2.24 and if you see confidence interval attains statistical significance. So constipation was more in patients who were continuously fed. Then they looked at a lot of different outcomes. They looked at mortality. If you see relative risk was 0.71 and this did not attain statistical. So there was no difference between continuous and intermittent. They looked at bacterial colonization. There was no difference between continuous or intermittent feeding. Then they looked at the risk of pneumonia. Pneumonia also, there was no difference between continuous and intermittent feeding. They looked at diarrhea. Diarrhea also, there was no difference between continuous and intermittent. And they looked at increased gastric residual volume. That also was not significant between continuous and intermittent. So this is one robust sort of a evidence that we have where they took a lot of trials, but they distilled out to 14 articles. In fact, they show in patients who are continuously fed, the risk of constipation was higher. But all the other endpoints they looked at with regards to mortality, bacterial colonization, pneumonia, diarrhea, gastric residual volume, there was no difference between continuous and intermittent. So these are the two myths that I thought I will put it across. So and this was the and what they argued is bolus speed. So it appears to be physiological and it limits interruption. So because when you're doing continuous, there may be a lot of reason when you may have to mobilize the patient and where you may have to stop the feeding or patient may want to go to toilet or so many other reasons. The interruptions can be more in continuous is what has been argued upon, and the mobility and the muscle tone also gets affected because the patient is getting feed. There may be a psychological interruption in mobilizing the patient, and that may have an sort of a deleterious effect on improving their muscle strength. Also, has been argued upon. And bolus feeds is found to be safe even for jejunal feeds and gastric feeds. So this is the sort of things that came out. And another important thing that came is the nighttime feed was found to be deleterious because it causes malalignment with the and none of us eat in the whole night. So we have to give that break. So circadian malalignment was found to happen and a lot of metabolic disorders was found to happen. It constituted important risk factors for cardiometabolic disease. And this was some of the studies which have looked into cardiometabolic disturbance when you feed in the night. So there is certain signals to tell us that maybe perhaps feeding in the night is something that we should all withstand. I think we also hold during the night times, and that is something we should do because that is not physiological. So anything that is not physiological, we should not do it. So this is the forest plot of the studies they took to look at the mortality between continuous and intermittent. As you see, the diamond doesn't cross the midline, and it was not statistically significant. This was just a forest plot to show the risk of pneumonia. And these were the studies they took. Again, you see the diamond did not cross. So today, friends, so we looked at two myths. So one is we looked at continuous versus intermittent, and we realized that intermittent or bolus feeding is good enough. The other myth we looked at is gastric and post-pyloric. So gastric feeding is good enough, and there was no major difference when you do post-pyloric. But of course, post-pyloric has a place, especially in complex abdominal surgeries where there is delayed gastric emptying. So that's the message for you guys. So thank you one and all. So I request you all to submit your valuable work to Journal of Acute Care. Of course, you can visit my website to rehear to this lecture. Thank you. So be with people who know your value, not your